and we're going to try to ensure that we do so more frequently. First of all, I want to use the opportunity to say that today is World Suicide Day, and it's a sober moment when you consider persons who take their own lives for various reasons. It's something that clearly we want to discourage. In fact, just looking at the statistics, based on the World Health Organization, every 40 seconds, someone in the world takes their own life. And the World Health Organization projects about 800,000 persons in the world do so in a given year. It is something that the country and the world needs to reflect on. And I want to just use the opportunity, starting these COVID conversations, to say that a byproduct of COVID, as we are seeing in a lot of studies that are now being done, is mental health, mental illness, and the manifestations of that are multiple. And we want to certainly, as part of the response and in recognition of World Suicide Day, just encourage our listeners, Jamaicans, those in the diaspora who are maybe tempted because of one challenge that they think they face or another, that there are better ways to dealing with those challenges. And we encourage them to seek help if those thoughts were to appear. From our perspective here, we have, in keeping with enhancing our mental health response, established a line, 888 New Life. That's the toll-free number, 888 New Life. And we say to all Jamaicans, or whomever you are in Jamaica, if those thoughts were to occur, if you feel depressed, down, hopeless, please call the number, and the public health system will seek to provide support in one way or the other with experts who are on the other end of the line. So in recognition of World Suicide Day, we encourage all of us to seek help if you need help. In terms of the regular updates, I'm going to begin today's COVID conversations with a statement and then go into the numbers. Because as we have been saying in recent weeks, the shift to community transmission also represents a shift in the approach that as a government and indeed as a country we must take to managing the spread of COVID, to mitigate against the risks, to discourage infection, to treat those who are infected, and to reintegrate or to integrate those who have recovered. And community transmission represents the high point, if you will, of the extent of the virus in the population. In other words, it represents the period that most persons will get or contract COVID, and by extension, more persons will transmit the virus to others. It means that it is likely that you will know someone who picks up the virus, who has the virus, or you yourself may have the virus. And the protocols around that are defined in best practices depicted or put out by the World Health Organization, PAHO, customized by the respective countries to suit their particular circumstances. And from our perspective in public health, and as part of the government of the day, we have a responsibility to adjust the protocols to fit the circumstances and the risks that we are now encountering as we move through the phases of this global pandemic. So as a Ministry of Health and Wellness, and we have indicated that we're in community transmission. And the question is, what does this mean? And we believe we need to say it a few times to get the information out. Dr. Webster Carr, who is the acting CMO today, our epidemiologist, will go into that in more details after I'm completed my own presentation. We say welcome to you, Dr. Webster Carr. And of course, the permanent secretary is here. The chief medical officer is off on a well-deserved break. But the focus today is around community transmission and a general approach to the management of this process, as well as more specific information around what this means. And of course, the numbers. So this is a time when, as the World Health Organization tells us, our resources, our approach, our efforts have to shift once we are defined or determined to have community transmission. Meaning, once the virus has spread throughout the population, where it can turn up anywhere, involving anybody, and there's no immediate recognition of where it came from to that particular individual. In other words, not readily traceable to an index case or an original source. Shifting the resources means monitoring the spread and characteristics of the virus. So there's a huge surveillance focus to monitor, because it is in monitoring you observe trends, and in the trends that you observe, you generate a response. Identifying and managing severe cases. So clinical treatment are now prioritized to those who need it most. Hospitalization will for those who require hospital care, those with severe symptoms. We describe them as mild, severe, or critical. Critical meaning the most extreme, which means a ventilator or an intensive care unit or a high dependency unit. Mild or severe would be the lower levels, but still requiring a constant doctor's monitoring and treatment. Community transmission means that we focus more on those individuals who are likely to be in the minority. Others will have to have a different kind of treatment, whether in their homes or in an institution that would be considered a halfway house, not exactly a hospital. Preventing onward transmission is a big focus, meaning public education, getting persons to respond so that they are not passing on the virus, and do so the best we can through individual responsibility, public action, community engagement, and that's what the community health aides and so on are for. So that's a big focus. Alleviating strains on the healthcare services, so addressing the internal dynamics and functioning of our hospitals, providing support to our healthcare workers, expanding where we need to expand our healthcare services, informing and keeping the public informed on recent developments, getting their feedback, getting their testimonials as to how they deal or are dealing with the issues, and satisfying any inquiries or any doubts, fears, anxieties that they have, and reducing the overall social and economic impact of the virus. So really trying to ensure that while we live with the virus, we manage the spread as best as possible to allow Jamaicans to be in a position to continue to live their normal lives, work, play, all the other things that they are accustomed to, social and economic. So community transmission does not envision totally shutting down the economy. Indeed, it envisions managing the spread to ensure that the economy continues to function. Both have to coexist. And this really captures the essence of the response in principle. And this set of principles or guidelines are guided by the World Health Organization, and based on our own consultations and where we are developing now a series of activities around that. It is a shift that necessitates a number of operational changes, including the effort to ensure our health facilities are sufficiently equipped for any surge in cases, while also increasing the complement of the health team. So when we speak about the 120 additional medical workers, the 1,000 community health aides, the additional public health inspectors for inspections, it's all a part of preparing the population. The new beds, the expansion in hospitals, or hospital beds or COVID wards, that's all a part of where the preparation is and the focus is in community transmission. The operational changes include the way in which at least some of our communication is handled, as we seek to ensure that members of the public are provided with timely information for sound decision making, because the public response is critical. As such, there are a couple of changes that we intend to make. Some we will be specific about today as it relates to the approach to communicating with the population. Others will come in the days ahead. As of tomorrow, Friday, September 11th, for example, as a first specific point, the update on the COVID-19 numbers will be provided by 10 a.m. each day, reflecting the verified numbers of the last 24 hours. Access to those numbers will be provided through our website, that is www.moh.gov.jm. So the Ministry of Health and Wellness's website, www.moh.gov.jm, and the link to those numbers will be provided on our social media platforms, which is at the moh.gov.jm. So every day, 10 a.m., we will upload the latest numbers on the website. So all who wants to see and get an update can visit the website. Our weekly press conferences and COVID conversations will continue during this phase, providing members of the media the chance to get behind the numbers while giving the public a better understanding of what they need to do to keep themselves safe while slowing transmission. So our weekly COVID conversations will focus less on the number of positives. That will be there, we update it each day, but more around how we manage under the community transmission phase. How do we restore normality while still coping with the issues around the COVID? We will also take stock of changing measures in place to enable COVID coping in the different settings. So looking at the home environment and the changes or the activities there, the school environment and the workplace. And this is in addition to looking at new approaches to testing and the evolving COVID-19 research agenda of the ministry. So the conversations will now zero in on living with COVID in a real sense, whether through testimonials, updates, expert commentary, looking in the respective environments, at the workplace, focusing on life with COVID as opposed to just about how many cases we have today, because we're already assuming, it is already established that community transmission will mean more cases, and that information will be available. While we continue to share infection prevention and control messages, from the need to wear masks to hand washing and sanitizing and adhering to quarantine, members of the public can also expect to hear more stories of the persons who have been impacted by COVID-19. This will include a look at the people living with or who have recovered, and the stories of persons who provide care to the most vulnerable. It really is, how do we cope, and what are the tips to support coping with COVID, given the acceptance that it is here and will be here for a while. We can also expect the public, that is, to see the enhanced focus on targeted community interventions. More than at any other time in our COVID-19 experience, it is now essential to deepen the effort to build community resilience to COVID-19. We want to ensure that community stakeholders understand what they are up against and that they are sufficiently empowered to respond, including through the training of community leaders or influencers. So part of the response will be to be in the communities, to train the community leaders and influencers, to get them to drive the influence on the behavioral changes in the community, and to respond to COVID cases in a way that manages the risks, even if you can't totally avoid it. And the focus from our perspective will be to push that line and that message and that agenda. In short, ladies and gentlemen, with the support of various partners, the ministry has done significant communications work for the national audience. We are now keen on ensuring that the information shared at the national level is appropriately received at the levels of the communities whose members we need to act in their own public health interests and on the basis of this information. That's, I hope, an attempt at beginning a process of shifting the dialogue based on the community transmission phase that we think is necessary for the country to appreciate and to buy into as part of how we develop the coping mechanisms and how we help each other so that we can overcome COVID while restoring a sense of normality to the population. This is not to suggest that the risks have gone away. It is not to suggest that COVID isn't out there. Indeed, COVID is there, and there more now than ever. But it is to also indicate that the approach to managing has to change. And in a sense, we will, while being cautious and careful and plan, we will have to accept that there's going to be cases. And the idea is to minimize deaths, minimize hospitalization, and provide the necessary care and influence that is necessary to overcome the virus over time. I want to also say that as part of this new approach in this phase, we will over the next week, and as minister, or recently appointed minister, the team and I have been consulting with a range of stakeholders over the last number of days, and we'll continue that into the next week as we seek to concretize a comprehensive plan that will represent the specifics of the shift in the approach to managing COVID under the community transmission phase. This will include testing protocols and the shifts that will take place there, the workplace protocols, the communication and public education, the clinical management, the infection prevention and control protocols, ports of entry management, the community intervention. And what we are doing now is, as said earlier, is consulting with stakeholders to sign off on these new approaches, helping those critical stakeholders to understand what the shift represents and why it is necessary. And I know there have been a lot of questions asked about tests and whether we're to test more and the types of tests, for example, or in the case of the private sector, issues around workplace protocols and why we need to change. There's going to have to be greater dialogue, and I'm committing myself to making that dialogue possible, either personally or with the team. And we are adding the final touches, except for the dialogue that will continue, and will unveil a more comprehensive plan that will represent the phase that we are in. So I wanted to make that statement as a starting of point for this evening's discussion, in keeping with the shift that is necessary given where we are in the phase of the COVID-19 pandemic. I think we have made progress in terms of how we have traveled. We did predict and forecast that we would get to this stage. We did delay the virus coming in through various methods to prepare for this. We're now here, and what we need to do is to live through the phase, manage as best as possible until we are able to complete that phase. And as I said a few days ago. The inflection point has started. We're moving up the curve in terms of the numbers. It will eventually taper off, and then it will come down. And we have to manage the process through to its end. And Dr. Webster-Carr will give better details on that shortly. Let me just quickly now just go through the numbers, given that today is still relatively the same, given the expectations of the populace who tune in for these discussions. So we have had today 2 new COVID-19 deaths. Is it 2 or 3? It's 2. Okay. We have the deceased are a 90-year-old male of a Kingston and St. Andrew address, and a 34-year-old female of St. James, whose death previously was reported to be under investigation. Both persons had comorbidities. And I've heard a discussion about whether or not we should say whether persons have comorbidities. I've been seeing some questions raised on social media and otherwise. The truth is, we respect the confidentiality of patient information, so no one will ever know who these persons are, at least not coming from the public health team. But I think it's important to make the link between the lifestyle diseases, NCDs, if you will, which is a dominant feature of our population based on our own choices that we make, and the vulnerabilities to this pandemic in the case of COVID-19. It's not a condemnation of those who are affected, but it does reflect the vulnerabilities, and hopefully will send a message to persons who know they have hypertension, cardiovascular disease, renal issues, that they should be particularly careful in order to avoid the picking up the virus, because picking up the virus will mean that they'll be more vulnerable. And if they have the virus, it means also that we have to provide particular care, recognizing their vulnerabilities. So it's really intended to encourage, even while we express regret, and to get a better appreciation and understanding of those who are impacted and some of the reasons why they are so severely. So we do express condolences to the families of the deceased, and will continue to do so to all those who have been affected. One death that was previously under investigation that has been determined to be a coincidental finding of COVID-19 is in a terminally ill 90-year-old female of a St. Catherine address. And coincidental death, again, the question was asked, means someone who died from other reasons, or from a particular reason, but not COVID. But then we discovered that they had COVID. So we had a gunshot victim that was 24-year-old who was operated on. We tried to save him at one of our institutions. He died, subsequently tested, and he had COVID. So that's coincidental. It did not claim their life, but they were infected with COVID. So the total number of deaths now stand at 40, which is a 1.1% of the total numbers. Total coincidental deaths of COVID-19 stands at 4. So 4 persons died of other reasons, but were COVID positive. And 3 more deaths in COVID-19 positive individuals remain under investigation. Jamaica confirmed COVID-19 cases are now up to 3,511, with the additional of 74 new positives in the last 24 hours. Recoveries have also increased by 32 to bring the total number of persons who have recovered and have been released from care to 1,051, or 29.9%. Details on new cases: of the 74 new confirmed cases, there were 40 females and 34 males. Their ages range from 4 years to 80 years. The cases were recorded in Kingston and St. Andrew, 29, in St. Catherine, 12, Portland, 11, Clarendon, 8, Manchester, 5, St. Ann, 4, Trelawney, 4, and St. Thomas, 1. And all 74 cases are under investigation. Active cases, 66.7%, 2,342, and are being monitored across the island. Some 71 or 2% of the cases on record have returned to their countries of origin. 26 patients are moderately ill, and there are 8 critically ill patients. So the 26 and the 8 represents 34, and those would be the prime targets for hospitalization. There are others in hospital for what other reasons, but just to give an example of how we segment who stays home and recovers versus who goes to the hospital. Classifications: 459 imported cases, 693 cases that are contacts of confirmed cases, 236 cases are related to the workplace cluster in St. Catherine, 251 are local transmission, not epidemiologically linked, and 1,872 cases are under investigation. High number under investigation, very much in keeping with the community transmission, because it's not readily clear how they picked up the virus. And that's why we define community transmission. Very important to appreciate that. It's not that we're not working or the team in the field isn't working. It's just that's just a critical feature of community transmission. In terms of gender breakdown, 55% or 1,931 females, 1,577 or 45% males, and the sex classification of 3 cases are being investigated. That means to be confirmed by the hospital or the institution. The ages of all confirmed cases ranges from 13 days to 97 years. There were some questions asked since yesterday when a 12-year-old was announced as one of the deceased. And again, our condolences to the family members. I just want to confirm, based on the many questions, that that youngster had significant other underlying issues. And that would have contributed to a large extent to his demise, and we regret to announce and express our condolences to his family. There are now 3 persons in facility quarantine and 26,028 in home quarantine. Challenge continues to be home quarantining, the only approach that can be taken. We continue to encourage persons to stay home, serve your quarantine period if you must, because you should, and we will reduce the rate of spread, because a lot of the breaches are manifesting themselves in the spread. So in closing, in this segment, I want to just again say to Jamaicans, let us remain vigilant. COVID is still very much present with us, still represents a threat, and perhaps represents a threat more now than ever, given the community transmission phase. Again, I say, assume that all you come in contact with, even your relatives and close friends, are potentially COVID positive cases. And so wearing the masks, the physical distancing, the sanitization is absolutely critical. Bear in mind, too, that if you are infected, you should protect yourself and protect others around you. And if you have underlying conditions, hypertension, diabetes, renal issues, cardiovascular disease, or any other such issue, a doctor should work with you to determine whether you should have hospital care or you recover from home or from some other facility. So today we had 2 additional deaths and 74 positive cases. And in keeping, however, with what we have said earlier, we're going to adjust our format to focus on living and coping with COVID, and we'll continue to keep you informed with that. I'm going to ask now Dr. Webster-Carr to quickly give us a brief overview using a number of charts and slides to show the spread of the virus. Dr. Webster-Carr.
Thank you, Minister. Good evening. So we're going to look at the numbers and what's behind the numbers. So the chart shows when persons had symptoms. And as you may be able to see, around August 8, 9, there was a sharp increase in cases and continues to have an increase in case. The next chart makes it a little simpler. in that it shows you clearly that there was what we call a turning point or the inflection point around the 8th of August. Around that time as well, it was estimated that our reproductive rate was 2.5. So what does it mean? The next chart will tell us what this estimated reproductive rate. So one person transmit to on average 2.5 persons in about 5 days. In another 5 days from that one person, we'll have 6. And another 5 days, 39 cases. So 1 person to 39 cases in 15 days. That's what it means to have a reproductive rate of about 2.5. And that's what we had around the 7th and 8th of August. And so this is the general picture of what's happening around the country, total, cumulative. But what is more important is what has happened in the last 14 days. So in the last 14 days, the next slide would show us the number of cases that are active in the last 14 days, or new cases. These are the persons that would suggest our own transmission of COVID-19, and that is about 1,000. The next one looks at the communities where we have these cases, and it spreads throughout the country. It's looking a little better today than it did yesterday, but as you can see, it's all over the country. And these are the cases that we know about. There may be persons that we don't know anything about. So this is throughout our country, in communities, in all parishes. So what is community transmission? We are having a larger outbreak of local transmission than we had at the beginning. If we remember the first chart, we are way higher. There's large number of cases that we can't link to anybody else. And so it's suggesting that we have large number of persons with COVID-19. The number of cases that we're getting back from the lab, or what we call our positivity rate, has been increasing over time. And then there are multiple cases or clusters throughout several areas of the country. And what the slide on the maps show where we were when the decision was made for community transmission. And so I'm going to talk a little bit now about the change in the discharge of persons from isolation. We have moved from a lab-based discharge in that in the early part of the outbreak, you had to have 2 negative consecutive swabs to be discharged. We have moved away from that because the science is showing that a lot of these cases after 10, 14 days are really dead particles. Because what the PCR test does is test in essence, the genetic material. If any of us watch forensic shows, even in a dead person, you can get the genetic material. So that's what was happening. So we were testing persons, and persons were out of work because they were returning a positive test. What is showing is that we don't need to do that. And so we have also moved to that, in that we are, once a person has done 14 days, and at least 3 of those they don't have symptoms before discharging. So over the next few days, you may see an increase in the number of recoveries as we move forward. So thank you.
Thank you very much, Dr. Webster Carr, our epidemiologist, who has done tremendous work. I want to commend her and her team, because all those lovely charts that you see put up and all the data placed in graphs and pie charts and everything else has been done by her team. And I know they go until very late in the night sometimes to meet the deadline. So I want to just say a big thank you to her and the team that she leads. It really is about how do we make the information available. And we really try as best as possible to make the information available, because it truly is important to us that you know, that you understand, and that your queries, your fears, anxieties, concerns are addressed so that you can be part of the solution. Very, very critical. I want to mention something here, and I before we go into questions, the COVID response globally has been experiencing very rapidly new developments around coming out of research, clinical research or otherwise, around treatment. Testing protocols are changing, approvals are being given to new approaches, and we adapt as we go along. And part of the unveiling of our measures for this phase come next week will be looking at, say, testing, for example. The antigen tests as opposed to the antibody tests as opposed to the PCR tests, and how we embrace based on the examinations that we have conducted and the objectives that we want to achieve. Sometimes we're accused of being slow to making those adjustments, but health authorities all over the world tends to be conservative, particularly when you're treating persons, and it has implications for their lives and their state of wellness. But there is a recognition that in this instance we have to move and we have to adjust as the methods are validated, verified, and approved by the respective authorities globally. And it truly is a collaborative effort. There's one such approach that the University Hospital of the West Indies has been engaged in, and this is approved by their own ethics committee, by their expert team, and that is the use of blood plasma for the treatment of positive cases. Essentially, and I'm being very simplistic now, they get positive cases, positive recovered cases, to donate blood, and they extract from that the plasma, which should have some antibodies, and they use that to treat existing positive cases, particularly, of course, more specifically, those who are being severely affected by COVID infection. So those who are vulnerable, comorbidities, older population, and so on. And the University Hospital of the West Indies has been encouraging and inviting persons that they treat to come forward. It's clearly a voluntary thing. There are confidentiality issues around that. And a number of persons have, in fact, having gone through the process and recovered, have donated their blood to help others. I raise it because there are other positive cases that have not been treated by the University Hospital of the West Indies throughout the country. And to the extent that anyone may feel compelled that they may want to be a part of that process, then I say to you, contact the University Hospital of the West Indies. Hear the details of it. I mean, all it is donating blood. So from your perspective, it's a relatively harmless procedure. From the patient perspective, or the person who will be treated, it could be a beneficial procedure. So it really is giving back based on the all of society approach to treating with the COVID response. And so I raise this and I say to Jamaicans, if you had COVID, you're recovered, you think that this is something you'd like to participate in, then contact the University Hospital of the West Indies. I'm sure they'll give you all the other details of this, and it may be worth your while to contribute to helping to treat with another patient to the extent that this method works. All right, thank you very much, Stephen. Can we go into questions now?
All right. Thank you very much, Minister. We're going to go, just reminding our media colleagues to use the Zoom feature, the raised hand feature on Zoom, to ask your questions. We're going to begin with Emma Lewis.
Yes, good evening. Good evening. I wanted quickly just to clarify something with Dr. Webster Kerr. Are you saying that recovered patients don't need to have 2 negative tests anymore? If so, what exactly is the procedure? Once they've done the 2 weeks quarantine, what checks are done? Are there any other tests done, or it's just they're released, they're discharged? I wasn't quite clear on that, sorry.
Okay, so once they have done the 2 weeks of isolation, an assessment is done, depending where they're at the hospital or at home. An assessment is done, and if everything is okay, then they are discharged from isolation, not requiring any tests.
Okay, thank you. And I was going to ask a question actually after that about recovered patients, how they are being monitored, if they are being monitored and checked up on after they have been discharged. I keep seeing something on social media that keeps popping up about, it's a hashtag, long COVID, meaning that after patients have recovered from COVID, they're still getting all kinds of odd symptoms. I saw something today of a woman who said she's had glaucoma. She now has glaucoma since recovering from COVID. I wondered what your position was on that and whether you're checking up on the recovered patients or doing any studies on how they're doing. Thank you.
Okay, so yes, thanks. They are followed up in the near future, 21 days, 7, 14, 21 days, by the team that we're managing, especially those who were admitted to hospital. With respect to a longer follow-up, there has been ethical approval obtained for a cohort study. And so that study will start shortly. But of course, persons will have to consent to be part of the study.
All right, thank you very much. I'm going to go to Janet Silvera.
Thank you. Good evening. My question is the regular question that I ask each time I come about travel authorization, and I'm being told the same thing over and over and over again. So I'm hoping that this is the last time that I'll have to come back and hear about travel authorization. In a group of persons, these are top producers for Jamaica, travel agents say that Jamaica is not necessarily interested in having visitors come in, owing to the fact that most of their clients cannot get approval even after testing negative. They say that their clients are going to Riviera Maya and Cancun, and our Jamaican hoteliers say that they are losing millions of dollars having opened their properties and now they're unable to get visitors. Another thing is the rapid testing. I believe the minister spoke about it in a sort of way. I'm not sure if that's what he was saying. But rapid testing is being accepted worldwide. When do we plan to start using similar tests? And when do we plan to start using private facilities outside of government labs to assist us? Because it's obvious that we're overwhelmed.
Okay, so in terms of the approval process, I don't know, I'd have to ask the PS to comment if there are any new developments there. I don't know that there are, but we can certainly follow up to see to what extent there have been any delays, as I understand it, there is a process, and once that process is followed, the approvals are normally granted. Am I correct in saying that?
You're correct.
I don't know if you want to expand any further on that, PS. And then speak on the test.
All right, thank you very much, Minister. First and foremost, we have had several conversations with stakeholders in the tourism industry where we have heard the complaints as you have outlined, and we have tracked the numbers. Now, one of the major reasons that some of the persons who apply on the system, especially persons who are tourists, they would have uploaded or provided incorrect information. Now, the portal had the feature of allowing persons to reapply within 48 hours. But what we're seeing is that that feature was kind of removed, and persons are applying the day of travel. And then when they are unable to get their approval on the day of travel, then they enter into difficulties at the airports. And so for us, we have had conversations with the tourism sector and the travel market to advise them that it's not practical for persons to apply on the system on the day of travel. And so we have reinstituted the 48-hour application restriction. So you must make good your application at least 48 hours before your date of travel. There are still some teething pains with the labs that are accredited, and sometimes when persons upload their tests, the labs are not accredited, and therefore we are unable to verify the veracity of the test result that is being provided, and so the application has to be rejected. These are some of the challenges that we are working through with the sector, and over time we anticipate that we will be able to streamline and persons will be able to understand the process better, and we'll get better outcomes. Thank you.
On the issue of the antibody testing, it is a conversation that is being had. There are some informal arrangements currently we know in the country where some persons are administering it. There are different varieties or manufacturers, if you will, but there is some value and in the use of both the antigen and antibody testing, as well as, of course, the PCR, which we're using now. There's going to be a meeting early new week. I think it's Tuesday. Yes. Tuesday, where I've asked for all the respective experts, if you will, with both the university, the National Public Health Lab, perhaps a few external experts to come together, where we are going to be having a serious dialogue, and a decision will be taken on where we go as it relates to testing. This is, of course, going to be guided by some of the protocols that I mentioned earlier coming out of the WHO PAHO. So I do anticipate that we will have a much clearer position, and this is the right time to have that position. I know it's a discussion that has been happening for some time, but there are a number of elements that have gone into how we have approached to date the testing protocols, but I think there is a need now to expand that, and the conversation will allow for that post Tuesday, just to ensure that all are on the same page.
Thank you very much. We're going to go to Brittany Clark from Nationwide.
Hello, good evening, everyone. All right, so my question is now, given the current spike in the COVID-19 cases island-wide and the concerns re capacity in our public hospitals, is the ministry considering or now reconsidering the construction of field hospitals, or does the ministry believe that enough is within the healthcare facilities to suffice, especially given that we are expecting, or the projection that we may be seeing, high confirmed numbers over the next few months? Thank you.
Okay, Brittany, thanks a lot. the expansion of capacity, and in particular beds, COVID beds, is very much an important part of the plans going forward. And in fact, we have made substantial progress. It was always a part of the plan, but it was part of a phased approach where we felt we would put it in place when we needed it most. And now is the time. So I'm happy to say, without giving too much specifics, that we have confirmed the arrival of one field hospital in the next week. In the 2 weeks. In the next 2 weeks, we're now building out the base for that facility. It will be located in the corporate area, and that field hospital will allow for an additional 80 plus or so beds. So that is in train as we speak, in collaboration with a bilateral partner. We will have an appropriate, unveiling of it and all that in another few weeks. There's another that is being pursued, which will be a similar field hospital that would be placed in the center of the island, on the south coast, actually. Yeah. And then there is a third that will be constructed in the west. So all told, we will add, a fair bit of capacity to providing additional beds. And you will see the manifestations of that over the next few weeks. So we are definitely moving in that direction as part of the preparation for what is happening.
All right, thank you very much. I'm going to go to Deion Jackson Miller.
All right, thank you so much. So first question is in relation to the deaths. Where would we be able to, or is the ministry doing a reassessment of the data in relation to deaths? And let me explain what I mean. So for instance, there was a day on which the ministry statements 3 COVID deaths and 3 under investigation. I understand the investigation process is to be done, but we at least 2 of those deaths had in fact been COVID deaths, but that now is announced on a different day. So where is the adjusted information that would then read, for instance, on 1st of September, for argument's sake, 5 COVID deaths or 6, as opposed to the 3 that had initially been announced? So that's one question. Second question, speaking about this phase of the pandemic management dealing with healthcare professionals, there had been a story in one of the papers about the doctors who had recently returned from Cuba and Russia, I think it was, and that there was a lag period in terms of their getting into the system. Can you update us on the situation with that? And final question, is the Ministry of Health's advice to organizations, businesses, and so on, has it changed in terms of how you respond to a positive case? Normally what has been happening is that the business, where everything would shut down for 2 days, and we hear there's deep cleaning going on and people moved into isolation and so on. Now with much more widespread transmission, does that same procedure still make sense? So that's the data on deaths, the doctors from Cuba and Russia, and the advice on deep cleaning and response to a positive.
Right. So I'm going to ask the acting CMO, Dr. Webster, to comment on the deaths and the recording of that information, and then we'll take it from there.
All right. Thanks, Minister. So deaths and cases we give based on date of onset for technical reporting. Date of confirmation or date of announcement is not necessarily what we use to, and so updating is based on the date of death and date of onset of of symptoms. So that's how we produce the data. So we would not be going back because it doesn't add to the information given. So we take it as a date of death, which may be different. So on the 6th, I think the day we announced 6 deaths, those deaths weren't from that day necessarily, but we were maybe got the confirmation of the test that day, but were not able to complete the investigation.
Okay. As it relates to the students, I'm being told that normally when doctors are trained elsewhere and they come into the country and want to be engaged, there's a process that involves them being certified, for want of a better word, by the medical council, which means assessing their documentation, all of the processes that they would have gone through for training. And then at the end of that period, then a conversation can be had. To be totally frank, I don't have the specifics of this group that you refer to, but I can certainly check on it and find out. But there is a process before you can be engaged, and I'm sure understandably so. What I'll say, of course, is that we have engaged the 121 medical officers. Those have been deployed, and we're doing engagement of others, the community health aides and so on. But in this case, we would need to check to see what the situation is. The other question that you asked was about workplace and the deep cleaning and whether there's a conversation there about adjustment. I know the permanent secretary and his team have been in conversation with the private sector, and there is a draft protocol that was circulated for discussion purposes. And I actually spoke to a few of the leaders this morning, and committed to having a meeting early new week to settle on a process that would vary somewhat from the current scenario of shutting down an entity for deep cleaning when a case is discovered within that entity. And it's not compromising the need for care to be taken to avoid spread, but it is an attempt, and again, we're guided. It's not just our position. It's an attempt to maintain normal operation while still being careful on how you manage the potential threat that a positive case may represent or would represent in an entity. It may vary from entity to entity depending on the structure and the formation and the type of business, but it is seeking to give better guidance or more guidance in the context of the likelihood of more persons being positive. I mean, in the early stages, Dion, when an individual was deemed positive in a company, it would be a big story. And I'm saying to persons, you're going to get more and more employees being positive and confirming their positive status. And it's going to be more the norm than the exception, because that's the nature or the feature, one of the features of community transmission. So when that happens, you do your contact tracing in the immediate surroundings, you apply a particular approach, you continuously apply that approach, whether you have that news or not, and mitigate against any risks, and also at the same time avoid a total shutdown of an entity. That's the general objective of it, and that's contained in the new protocol or the draft that has been circulated, which is going to be the subject of conversation over the next week, and then at which point will be announced as the new approach.
Thank you, Minister. We'll go to Leanne from Styles FM.
Hi, good evening. Can you hear me?
Yes, go ahead, please.
Okay, I have two questions, right? There are several persons here in Portland, and when I say several, I mean several, who are awaiting their COVID-19 test results. Those persons, a lot of them would have already gone over 14 days quarantine and would love to go back to work. they would love to take a negative statement of some kind to their bosses to state that they are negative. So that has led me to wonder if there's a backlog on the testing, or is it that if they are negative, they do not get back a response? The second one speaks to ventilators. I know type C hospitals don't carry ICU. So with the establishment of COVID wards in these hospitals, are there ventilators available? And if not, is there an understanding or agreement with the type A hospitals to accept critically ill patients who may be in need of ICU care? Thank you.
Okay, I don't think I got the first question. Did you? I wasn't sure I understood that I.
The first question is a two-part. I'm asking if there is backlog, or is it that if tests are negative, persons do not necessarily get feedback that it's negative, because persons are waiting now over 14 days and haven't gotten back a result to take back to work to say, yes, COVID-19 negative.
Yeah, so everybody should get a feedback. So based on where the test was done, they would need to check with that facility. We don't have a 2-week backlog. So if they have done it, if they did it over 2 weeks, then they should have had a result by now.
Okay, and in relation to the second question, second part of the question about having a ventilator in a type C hospital, it's unusual because normally those are reserved for intensive care or high dependency care, and those are normally in the B and A type facilities. There's always a protocol of transferring patients who need intensive care, critically ill patients, whether it's COVID or something else, to hospitals that have the facilities and the experts, for that matter, the advanced training or capacity to transfer them to those facilities for treatment. So yes, that arrangement is a standard protocol.
Thank you very much. We're going to go to Jamaica Social.
Hi, can you hear me, folks?
Yes, go ahead, please.
Okay, I'm Cassius Watson for Jamaica Social. I'm just, the person speaking there from Portland, from Styles FM, touched on what I was going to speak about. Regarding testing, is it a situation that I know at one point we had equipment that could facilitate up to 3,000 tests, I understand, at peak. But it seems like our testing numbers are down, and I can't think of anyone who gotten their test results less than 5 or 6 days, in less than 5 or 6 days in recent times from the number of people that have reached out to me. It then doesn't that feed into the struggles you're having with contact tracing, because after a certain amount of days, it's almost impossible for you to trace if you're not getting test results in time, and that person would have gone on and spread the virus to possibly scores of other people. Isn't that playing into the numbers that we're seeing now, the fact that our testing turnaround is just too long? Thanks.
On that, I mean, the testing has been an issue from time to time, not all the time, but from time to time, and there are several reasons why it has been an issue. Sorry, in the early stages it would have been capacity. In the mid stages it would have been downtime for one reason or the other. It would have been capacity at one stage when we tried to test all coming in. And now we're at a stage where we are trying to manage the adjustments that are going to happen given community transmission, where the protocol around testing will change and the type of tests that are administered would be adjusted. Spoke to the meeting on Tuesday, and hopefully over time, in not too long time that is, we will see a testing mechanism or protocol that suits the particular purpose. So I'll be prepared to accept that there have been issues, but I think for the most part it has served our purposes in terms of assessing the virus, the spread, and where the risks are and how to approach the risks. Part of the challenge we're facing now is that, you know, even with the least symptom or even with no symptom at all, the fact that someone feels that they have been exposed to someone with the virus, they want to do a test. And in one sense, it serves an important purpose to do that test. In another sense, it becomes counterproductive because it creates a rush on the process, and it may not be necessary in a number of those cases. In fact, the over-focus or over-emphasis on testing is misplaced based on all the evidence that we have seen and based on the phase in which we are now, which is the community spread phase, the community transmission phase. I know it's a difficult concept to understand, given all that has been said in the past about the importance of testing. And I know that we're going to have to try harder to explain it and to explain the difference between what do you call it, a clinical diagnosis as opposed to a lab diagnosis, right? A laboratory diagnosis, which is a function of testing, versus a clinical diagnosis, which is function of a doctor's examination and assessment. You know, to parallel dengue, there is an assumption in the dengue response, because of the history of dengue in Jamaica, that you only test a particular percentage of the population, and for the majority of the rest, a determination is made based on symptoms. The doctor assesses, because we have developed a track record of identifying what the common symptoms are, and then reserving testing for the more severe cases while prescribing an approach to persons who are suspected cases. In a sense, we're moving in that direction. Well, not in a sense, we are moving in that direction, but it's going to require deeper explanation. And our burden at the ministry is going to have to be to explain that sufficiently and simply so that the population understands and appreciates it and knows why, and similarly so that they respond to any directive that is provided to them, even if they have not been tested. And sorry to be long-winded about it, but it's part of my own struggle to understand and appreciate as a non-clinical mind. I can imagine how it comes across to you or to the populace who may not be at my vantage point in hearing the experts speak to it. But we're going to try our best to get an appreciation and understanding of it. I don't know if you want to comment further, Dr. Webster, that want to say anything else? No? Yes? No. She says no, okay. All right, so in the next week or so, we'll provide better particulars and more particulars on this.
All right, thank you very much, Minister. We're going to go to Romardo Lyons from the Star.
Good evening. Are you hearing me?
Yes.
All right. I have 3 questions. Number 1, why hasn't the health ministry engaged the community health aides who have been trained? And what's the timeline for employing them? The last time we heard, the ministry was seeking 1,300 residents for such. Number 2, apart from the increase in cases and Jamaica now experiencing a community spread, is there anything else linked to the increase in the number of cases? And finally, what is the risk level at this stage for persons living with asthma?
All right, so the first question is about engaging the community health aides. The community health aides have to be trained, and they are trained in phases, not all at once. And we have actually engaged a number of them who are deployed. I think it's about 700 at the last count. So I'm not sure why that information would suggest otherwise. I mean, in fact, I've been around the country speaking with a number of them in training, and I know a number of them have gone out in the field. But we have to complete the process, and that process is going on in earnest. So it will be completed. They are a very important part of the response. The other question, I'm going to ask Dr. Webster-Carr to respond.
Okay, thank you. The increase in deaths was the next question. So we are seeing an increase in number of cases and also symptomatic cases. We have a greater proportion of symptomatic persons being identified now than we had earlier in the outbreak. And really, these are the persons who are coming to our health facilities, whether health centers, private doctors, or hospitals. And so we would have more adverse outcomes and the deaths. The deaths usually lag 2 weeks or 3 weeks behind the increase in cases. So when we start seeing an increase in cases, we are about 3 weeks down the road right now, and hence we're seeing more deaths. With respect to asthma, asthma is one of the chronic non-communicable diseases, and it affects the lungs. So can you imagine having an infection that affects the respiratory system on top of having asthma? It increases your risk for a more severe outcome. So it is a risk factor.
Thank you very much. We're going to have a follow-up from Dion Jackson-Miller.
Thank you so much. Dr. Webster-Carr, your response didn't completely address my concern in relation to the data about deaths. Now, I hear you saying that you don't need to readjust because it's based on the date of death, but recall that's not the information you give us. And I look back on one of the releases just to be sure. So what we're told on any given day is that there have been 2 COVID deaths. Now, I understand that's information from for the general public, but some of us actually like detailed information so we can actually track what is exactly happening on a day-to-day or week-to-week process basis. And because we don't have that information about dates of death, we actually don't know how many people actually died from COVID on a given day. So you clearly have that information, but that's not information you're sharing in sufficient detail with the public so we can know that. We can't do our own tabulation either because of the same problem. We don't know the day on which these people died. So we could be getting information over the course of a week when all of them could have died on the same day. So that's what I'm asking. Where is that information? When can we get that? Where will that be for us to access?
Okay, so we'll look at it. I know some days we do give the date of death, probably are not consistent with that. So we'll review that and have some way of communicating that. Over.
Can I just add, if I may, a slightly separate issue that the Ministry of Finance has approved the risk allowance for the frontline workers. There was a suspension because the time period that was given had expired, and now it has been extended for an additional 6 months. So to the frontline workers who were where we had that commitment and were actually receiving the risk allowance, we will now continue that process given the approval of the Ministry of Finance. I'd like to also just reiterate the point about deaths and the relationship between increased deaths and increased positivity. It's kind of logical. I mean, if you have more cases, the likelihood of persons who are most vulnerable, the old, those with comorbidities, the hypertension, diabetes, renal failure, all of that you're going to have more of those persons having the virus. It's not desirable, but it's more likely. the probability of it happening is more likely. And to the extent that those persons are infected or affected, then it will certainly increase the possibility of critical cases. And in extreme cases, you will have more deaths. So it is why we focus in the strategy on vulnerable groups, which is why we reserve hospital beds for those that are critically ill, to increase their chances of overcoming the virus. And it works in most cases, but unfortunately in others it doesn't. And that's the risk that we take as part of the virus being in the population.
All right, thank you very much. We're going to go to Debbie Ann Wright.
Good evening. I just wanted to speak a little bit about UHWI. Recently, we had an
Debbie, you're still there? We're not hearing you. All right, let's come back to Debbie. We're going to go to Janet Silvera for a follow-up.
Thank you very much. I want to speak, the PS, Permanent Secretary, responded to the travel authorization, and he has said this before, but those persons that I have spoken with, and there are many, said that they made the application days ahead. They took their test, they made it days ahead. So it's not persons who are applying a day before, but several days before, yet they are still unable to get the authorization. He says that persons are applying just before traveling. These persons are saying, no, that is not the case.
Okay, thank you very much. So, as I said before, we track the numbers on the Jam COVID and the Visit Jamaica website on a daily basis, and I can tell you, as at every 2 o'clock every day, we do the evaluation to determine two things. One, whether or not the applications that we have received is of such a volume that we have to do what is called a sprint to clear the applications to ensure that everyone who is traveling within the next 48 hours are cleared to travel. Now, based on the analysis that we have in terms of the data that we have, we clear the applications. As I said before, we can look back at the overall process and assess whether or not there's any glitch in the system that is causing the concerns that you're outlining. But from our end, our process tries to ensure that we clear the applications that are 48 hours ahead. As I said before, there are instances where when we clear the application that are 48 hours ahead, someone would have uploaded incorrect information or incorrect test results. Either they upload an antibody test instead of a PCR test, or they upload a test result from a lab that is not accredited, and therefore the system rejects, or the application is rejected. And then because we have approved in that 48 hours, the timeline for them to reapply and to adjust for the incorrect submission is limited, and it presents a problem for them when they need to travel. But as I said, we will look back at the process, we'll look back at the system, because obviously we still have some challenges in the market, the travel market, and we will have to make whatever adjustments that are necessary to reduce or eliminate the complaints as you are outlining.
Thank you very much. I think we have two questions. Let's just try Debbie Ann again.
Right, are you hearing me? No?
Yes, we are.
Okay, I was asking what's the situation with bed spaces now at UHWI, because we're seeing again some reports that persons are being turned away even though they're ill because they're being told that there aren't enough spaces. Also wanted to know what's the situation in terms of the workload for the medical staff there. Has that improved?
The situation at UHWI, as I understand it, has improved. In fact, we had an all-day meeting today with all the units, the departments, and institutions. UWI was present. They made a presentation. As I understand it, when they had that space issue, they opened up a new wing to add 24 beds to the 17 COVID beds they had and 16 suspected, used for suspected cases, which were full at the time. So they added an additional 24 beds, and they had, therefore, space to accommodate more. I don't know if the situation has changed as of today, but that situation was addressed at that time, and my understanding was that it was under control. As it relates to the staff, there have been several meetings, as I understand it, between the management of the university hospital and the particular segment of the staff that had issues, and those meetings were intended to address those issues. I have not received, since that time, any additional information to suggest that the problem persists, and I'm assuming, therefore, given that I was with them today, the senior management, that if there was an issue, it would have been brought up, and it was not. So I have to conclude, although I'm willing to check, that there seems to be a solution or resolution to that challenge.
All right, thanks, Minister. Just a final question from Damon Mitchell from the Gleaner. He's asking, has the government discussed the possibility of early release for low-risk, short-sentence prisoners as an option if the situation worsens in the penal facilities?
The short answer to that is no. Clearly, we're not assigned to that portfolio, but I have not been part of any discussion related to that. But I go further to say that I don't know that there's a crisis in the penal system in the prisons. Beyond the fact that we did have an issue in one particular facility, and we did move in, do some contact tracing, isolate persons, and did some follow-up testing. I can't say.
We got back results today, they were negative.
Oh, okay. So I'm being told, late breaking news, that we got back the results today. How many did you test?
We got back 24 today.
Okay, so I'm told that 24 test results came back today of persons who were close enough to those positive cases, and they were all negative. So that's good. That's good news. So I don't see that there is a need, based on the COVID response, to consider what you're proposing, and it certainly hasn't been discussed.
All right. Thank you very much, Minister, and thanks to our colleagues on the Zoom platform for their questions. I'm just going to hand back to Minister for his closing remarks.
Okay, so my remarks will be brief. I just want to again say to those listening and watching, thank you on behalf of the team for participating in another COVID conversation. Tonight, we discussed the community transmission phase, as we believe we should, and do so more than once for better understanding. We outlined the adjustments that will be made over time, including to these conversations that we will have to focus on living with COVID, to get the perspective of communities, of individuals, to give support around the information and to empower citizens in their response, in their everyday dealings, so that they can be sufficiently aware to minimize the risks to themselves and to others, to prepare the hospital system to treat with those who are affected, to minimize the risks to them, and to generally try to exist with COVID and to normalize the functioning of our society or economy to benefit from the normalization of both the social as well as the economic. And that's the general approach. We did say also that next week, having gone through a period of discussion with stakeholders, we will unveil a more comprehensive and specific plan around the new measures, new protocols involving testing, workplace protocols, clinical procedures, or hospital care, ports of entry care protocols. And we're hoping that that will become the sort of new norm to the population. We've also said that we will upload by 10 each day, 10 a.m. that is, the information around the numbers, the number of cases, the very information that we normally send out in the nights, normally on my page and then on all the other pages. We will upload that information on the Ministry of Health website, and it may take the form of a chart, and so persons can get those numbers each day based on the last 24-hour results. And finally, we did give an update on today that we've had 2 additional deaths and 74 additional positive cases, just to keep the public informed as to where we are in terms of the latest statistics. Let me say thanks again for the support and to thank the Jamaican people for being part of this process. We will overcome the process and the threat that it represents. We have to work together. It's really an all of society approach, and the government of the day is committed to continuing the dialogue to ensure that Jamaicans are kept up to date and engaged and involved, and that they define a role for themselves as we seek to overcome the risks associated with COVID. I want to close, although this is COVID conversations, by saying we are now approaching the dengue period, and there will be a plan unveiled and communication to the populace around the control of breeding sites, and you'll hear more about that. But I want to encourage Jamaicans to remember that dengue is still out there. The Aedes aegypti mosquito is still out there, and what we really don't want is a dengue outbreak with a COVID community transmission. That combination would be quite challenging for us. Certainly the hospital system and its response, it would be difficult. And so I urge Jamaicans to take note and protect your environment, get rid of breeding sites, be aware, and we will have an increased fogging schedule that will take in weekends across the communities, across the country, as part of our control measures for dengue. Thank you very much. Have a good night and have a good weekend.